All right, good morning. I'm Dr. Chad Versio, the Chair of Pediatrics here at RUHS. We are lucky to have with us our Chief Informatics Health Officer, Dr. Vikram Kumar, and then Tammy Lowe, our Director of the Nursing and the ICUs. And we're going to talk about planning, response, and tracking of metrics within the hospital so that we can respond appropriately to changing situations. First, we're going to go through the county statistics. For Riverside County, so far, we've tested 123,000 people with just over 8,000 confirmed positive. We currently have 200 hospitalized patients with about 62 in the ICU. The hospitalized has gone down a fair amount, but the ICU has only gone down a little bit across the county. We have 342 deaths in the county. And then if you can look and see the new cases by day, those have creeped up a little bit over the last week. And we're not sure exactly what's going to happen, of course, with these protests and that kind of thing, where people are coming in closer contact with large groups of people. So undetermined as far as how that will go forward. For San Bernardino County, they have about 5,000 confirmed cases. So Riverside County, our doubling time is about 30 days or so. San Bernardino's is about 16 days. They have had 208 deaths. The interesting thing about the deaths is that, for the known cases, the fatality rate continues to be about 4%, which is, that's been across countries. It's come down, in some countries it's been as high as 6 or 7%. But for the known cases, it seems like it's holding steady for about 4%. Then San Bernardino County has done 64,000 tests. Their hospital census across the county has been fairly stable. If they have some nice graphs on the county website that you can see, and basically the COVID positive patients and suspected have been fairly stable, with the suspected actually coming down. And then the ICU capacity, the ICU cases have been, they have 53 COVID positive ICU patients across the county, 10 PUIs, but overall have been pretty stable for over the last month. So those are the statistics for the local area. I'm going to turn it over right now to Dr. Vikram Kumar, who's going to talk a little bit about how we have approached this topic of tracking within the institution.
Thank you, Dr. Versio. Good morning, everyone. Vikram Kumar. I'm the Chief Health Information Officer here at the Riverside University Health System. I'm a pediatrician and training. I work mostly in IT. Going back to March, we started having conversations in the medical center on how best to track our COVID cases, and then maybe even setting some thresholds as we started going past the surge preparations into reopening conversations on how best to monitor that, and what would be good thresholds to track over a period of time in case we get another surge or we have utilization issues and so on. So I'm hoping you can see my screen. This is a 2-page dashboard that we've developed here at RUHS. And I'm just going to go through the boxes at a high level. And we also have Tammy Lowe, one of our nursing directors over ICU, who will get into a little bit more detail on some of the workflows and utilization of the ICU areas and such. So starting at the top, it gives us an overall high-level estimate of the number of cases. So we have the total PUIs, the persons under investigation, that is, plus the COVID. So that's everyone that has come in that has had a lab test done for COVID or is in isolation for COVID. And of those, you'll see that a fair percentage are positive. And the same applies to the ICU. And then we talked about looking at our med center occupancy itself. So we have, a little over 360 beds at the main medical center, that is, and we set some thresholds on what would be, the green level of utilization and where we may need to take a pause and possibly where we may need to stop some of our reopening processes in anticipation of a surge or high volumes. And the same applies to our ICU. Our ICU tends to be quite busy. We have some redundancies with our ICU bed capacity, which I think Tammy will get into in a little bit. So this, the occupancy visual gives a high-level snapshot of where our med center is and where the ICU is on a daily basis. And then starting with the first column, if you will, you'll see that the hospital admissions, they've bounced around a little bit overall, and they're starting to stabilize. There's a slight downward trend compared to historical numbers with hospital admissions. But those numbers are slowly starting to pick up now. And then of those, you'll see that where the COVID admissions are as a part of that entire picture. And then getting into, the number of hospitalized at any given time, you'll see that, our COVID numbers they peaked around the second week of April, as in most other hospital systems. And then they hit a new level. And since then, they've been quite stable. We haven't seen a real, change. It's just a new normal, it seems like. So we tend to average at any given time about 45, 50 patients that overall have a PUI or a COVID plus status. And of those, 35 to 40 in the medical center tend to be COVID positive. And our ICU census for PUIs and COVID tends to fluctuate, in that 10 to 15 range for the PUI and COVID positives, and maybe in the 8 to 12 range for the COVID positives. We also track the length of stay, and this, as you will understand, is a long-term visual. It doesn't change too much, the trends that is on a daily basis. And you can see that on average, our COVID positive patients spend a lot more time compared to the PUIs and also compared to our average length of stay for all patients. Going down the ICU column, I talked about the occupancy. We track our ICU admissions, and on an average, we get a couple of admissions to the ICU for either COVID positive or PUI on a daily basis. Most of those tend to come through our ED, but some tend to be transfers from within the hospital or one of our clinics or other hospitals. Our ICU census did go down a little bit during the first couple of weeks in May, but then it's starting to pick up again, the overall ICU census. And our COVID plus and PUI census has tended to be stable. We hit a little bit of a peak, like I said before, around mid-April, and then we've stabilized to a new normal. And then quickly, we track our ICU length of stay for COVID positives and PUIs and also our ventilator days. And as expected, you would see that the COVID positives tend to be more than with the utilization that is than the PUIs. We also decided to track, our medication utilization for anakinra, hydroxychloroquine, remdesivir, and tocilizumab. And you can see that initially there was quite a bit of utilization with hydroxychloroquine, and that utilization has come down. And the utilization with that you see now, the light blue line, is mostly patients that have rheumatological or lupus-related issues that are hospitalized. So we're not using it for our COVID patients. And we have started to utilize some remdesivir based on supplies through FEMA that is distributed to the hospital systems in the county. And then we also have utilization with our rapid diagnostic test. This test is mostly used for patients that come in for procedures or have emergent need for procedures where a regular test and a 2 to 3 day turnaround is not possible. And we also set some thresholds for that because we want to be cognizant to the fact that one, we have limited number of supply kits. And also, the lab can only run a certain number of tests at any given time and a certain number of tests a day, and also depending on the time of the day. So that's the intent, to track it and also set some thresholds. Our ED census, going to the last column, has slowly started increasing over the last few weeks, and we're starting to see some trauma and other routine ED visits. And our ED utilization of the COVID orders, the ED and inpatient utilization of our COVID orders, is another way of looking at how many COVID positives and PUIs we screen at any given time in the inpatient and ED setup. And that has almost stayed stable. It has it was quite high in the second and third weeks of April, and since then it has pretty much stabilized. And then the last quadrant, lower right quadrant, we have the supplies with PPE, and broadly we get a visual on the supply, if it is less than 3 days, or we have sufficient supplies for up to 2 weeks or more than 2 weeks. Going down to the next page, and I'll be quick before I turn it over to Tammy. And this is, a slightly different way of looking at some of that information. We have the total hospitalized. Some of the graphics get into the cumulative admissions and COVID positives over a period of time. We've also broken it down by total new admissions, positives, and negatives weekly. And it also shows to some extent, how many of those admissions converted to positives, and what percentage of those converted to negatives. So that has remained stable over the month of May. We also provide a high-level visual around our total positives in the county, and the positivity rate in our county, which is also important to follow, tends to be less than 8%. It tends to fluctuate around 6-7%.
So he's probably somebody from
if you could please put your phones on mute.
There's
Thank you.
usually like 17 hospitals in the county.
And then we have, the California and Riverside County numbers with total ordered positives, and the comparisons in the parentheses is the previous days. And then in the lower right quadrant, we have tracings of hospital COVID positives. And as expected, you'll see an uptick in the mid-weeks of April. And since then, like I said, we haven't seen the numbers come down close to zero. We are still seeing significant numbers across the county, and they tend to fluctuate around the 200 mark for COVID positives for inpatients, and around the 60 to 70 mark for ICU COVID positives. So this is across the county, and then there are daily fluctuations. And then the last visual in the lower right quadrant is the 7-day change with our COVID positive hospitalized. And you see the steep uptick around the second and third weeks of April. And since then, like I indicated, it has come down. But it has stabilized around, I think weekly we have about 1,200 to 1,400 admissions for COVID positive any given week. And that trend has pretty much stabilized over the last 3 or 4 weeks. One final observation is that with the county, just over the last couple of weeks since some of the social distancing norms were relaxed, we are starting to see a slight increase with the number of cases, and that at any given time, on any given day, I think I would say we get about 150 to 200 new cases, new positives by date across the county, and that number is slightly ticking up over the period of time. And we are also screening more and more patients, but even with that, we are seeing a slight uptick of cases. So I'll pause there and turn it over to Tammy.
Well, I wanted to ask a quick question, Vikram, because that will maybe help us transition to the conversation that we want to hear from Tammy. if you can go back to the previous page, I just wanted to hear a little bit about how the group that was kind of helping put this together, thought about, these, the continue versus slow versus stop and revert kind of trigger points. What things did you take into consideration when you kind of put those different, stages together?
Sure. Good question, Chad. And, so going back, we started this, having discussions around this around the last week of March, early April, when we were still anticipating a surge. So part of the conversation, and so we had by that time closed down most of our regular operations in anticipation of the surge. So the conversation started around once a surge hits and then it plateaus and then starts to trend downwards. What are thresholds that we need to look for as far as how we can keep reopening these areas as they start coming up? So be that clinic spaces or return to elective procedures and other procedures in the ORs and clinics and so on. So we thought, the occupancy is one of the main factors. So we set thresholds that are about 70% of our total occupancy for continuing with the reopening, and then 80 to 90% we would stop that reopening and take, a pause, if you will, and see if we can continue or not. So that was the threshold that we set for occupancy, for example. And similarly, we had a similar percentage of ICU occupancy that we had set. And I also want to reiterate that even though we have thresholds for each of these different data sets, it's a composite. If everything turns red, then we know that we will struggle with our utilization. We would know that we are getting hit with a surge or either COVID or some other type of surge where our utilization is off the roof, and we're going to struggle with keeping up with routine operations, that we may need to take a pause and revisit where we are. And then the same applies to medication utilization. The conversation initially was around hydroxychloroquine and the potential SARS shortage, and then quickly that turned over to remdesivir and the supply and demand and who we prioritize that for. But if that supply continues to remain, and then we start seeing, let's say, an uptick of cases come fall or winter, then that's where we have set up some weekly thresholds for medication doses, that is, on where it just gives us, I don't think it's one visual that gives us all this information. It's a composite that taking into account everything. And then if we start seeing a lot more of these tracings be in the red range, or in the deep red range, then it's telling us that we are starting to bump up against what we can safely perform, and the availability of resources, both human resources and other resources, would start to bog our operations down.
Okay, thank you. All right, Tammy. I think you have been heavily involved in the planning of response as we kind of look at this, phased reopening, and how ICU, the ICUs have had to be very flexible. So, I think it'd be helpful for us to hear kind of how you're planning to do that going forward, what kinds of things we're doing locally, and what should other institutions consider doing.
Yeah, good morning. So we have had to be very flexible as this has really sort of ebbed and flowed and has been a very fluid process. So initially, I feel like our hospital did a very good job with pre-planning. We started meeting in executive committees every morning, 7 days a week, to try to plan for obviously this crisis. And then we broke down into smaller meetings. The meetings that I was particularly involved in were geared towards critical care and how we would manage not just the overflow, but how we would manage our patients. So we really combed literature, what is the best practice for these patients, and things were coming out daily. So Our physicians were heavily involved. We worked together as a team with our MICU physicians and our SICU physicians, pharmacy, infection control. We really came together as a team for this to try to plan to mitigate as many barriers as possible. And so initially, we have a 12-bed, prior to COVID, we have a 12-bed surgical trauma ICU and a 24-bed medical ICU. So our plan was to start our COVID unit in our 12-bed ICU and move all of our patients to our medical ICU. And that worked very well for a while until we started to peak. Then we realized that we were going to overflow COVID and overflow our medical surgical 24-bed ICU. So we came together and brainstormed ideas, and for our hospital, the best option at that time was to overflow into pre-op holding, which had 6 to 7 beds that we could use for non-COVID patients. So then we switched our ICUs and put our non-COVID in the 12-bed ICU and pre-op holding, which are in close proximity to each other. Our census at its height in our COVID, which was a 24-bed ICU, went up to 20 patients. We came up with a lot of staffing, creative staffing ideas to help in those departments because, as everyone knows, it's very arduous, the PPE process of donning and doffing and a lot of PPE shortage. So we utilized non-ICU staff to help us with being runners and that sort of thing. As our census, as Dr. Kumar spoke to earlier, as our census started to go down, then we took advantage of that and switched back our ICUs so that our medical surgical ICU, which in the summertime is where our census goes up with trauma type patients. We were averaging about 6 to 7 a day for about a week, and then there was, in the communities, there started to be disruption and rioting and protesting, which brought a lot of people together. We started to get concerned about that, and we thought we better start to plan early. We've been, 6 days into this, but we already saw our census in our COVID unit starting to rise. So we've been averaging about 8 to 10 patients a day, PUI and COVID. So we started to think, how could we better plan for this? So we looked around the hospital and looked at different spots that we could potentially move into should we have to flip our ICUs back, or could we just overflow into other areas? So our newborn nursery is an area that could hold up to 10 ICU patients in full beds. And we had kind of started looking at that early on, when we were sort of fearful that we might have 160 to 170 COVID patients, ICU COVID patients. So we've been working on converting our newborn nursery into a non-COVID ICU, and we still have the ability to overflow into pre-op holding right now. We'd like to vacate that area to keep the OR clear. And then now with our COVID patients census starting to rise, as you can see with Dr. Kumar's graph, we are looking to overflow into our step-down unit, our 2,500 unit, with some of our COVID patients that are not as critical as other patients. One of the lessons that we learned early on is trying to manage these patients off of the ventilator, and we've been very successful at that. And I think that's probably one of the reasons that our mortality is pretty low, relatively low for COVID. So we keep the patients on high flow oxygen, either vapotherm or BiPAP. That way we can oxygenate them with 100% oxygen without ventilating them. Because what we found out when we put patients on ventilators, they've stayed on ventilators for a long time. The ventilator days are essentially doubled when a patient has COVID. So we try very hard. Today we have 2 ventilated patients. Most of the time we only have 1 ventilated patient out of maybe 10 in our COVID unit. So our more stable patients that we are proning or that are self-proning and are on high flow oxygen, but otherwise vital signs are stable, oxygenation is stable, those are the patients that we will move to our PCU unit. We have trained our PCU nurses to float to ICU, so they can take care of lower level ICU patients in our department on an everyday basis when that need arises. And so we're going to be meeting today to look at the whole picture with the step down, the intermediate care manager, to try to mitigate concerns of putting ICU patients in 2,500. You have to take into account, nursing fears and provide support to those nurses so that they can be successful taking care of those patients. There's a lot of little caveats that go with all of this, but what we've found, no matter where we've surged throughout the hospital, is when you provide a lot of support and a lot of presence with the nurses, it has really made the process go better. If we currently we have our step down unit that's closest to our ICU is our intermediate care COVID unit, and that department can handle up to 27 COVID patients currently, and then 4,500 is our non-COVID med surge department, and that department can hold up to 28. Out of the ICU, our average for the last few weeks has been around 30, 32 patients in those departments, with probably 25 to 28 of those being actually positive. So if we overflow into 2,500, we could essentially take up 10 beds there, which would give us 22 beds. And even at our peak surge, we only hit about 20. So we're really kind of hoping that with this community crisis, that our numbers don't spike as high as they did before. But if they do, we're planning for that. We want to be ahead of the game, as we have been pretty much so far. And I think pre-planning is very important. And having workflows and educating the staff, physicians, and nurses to understand where we will be overflowing, why we will be overflowing into those places, and how we can manage that appropriately.
Okay, thank you, Tammy. I don't know if anybody on the call has any questions. If you do, if you can put them into the chat box. Okay. All right. Well, thank you so much, Dr. Kumar and Tammy, for joining us this morning. It's very helpful information to hear how we're planning here at RUHS, and hopefully that will also assist other institutions as they're kind of considering how to move forward as we kind of do the staged reopening, and we are expecting to see some degree of increase in patients, but how we plan for that and maintain the services that we need to provide for other patients. So thank you for joining us this morning.
Thank you.